Wonderful. So thank you again for that introduction. Like she mentioned, the title of my presentation is Application of TPMT and NUDT15 Testing for Azathioprine and Liver Transplant Recipients. I have no financial relationships to disclose. Starting off with the medication, so azathioprine, the mechanism of action, it's a prodrug for mercaptopurine. The active metabolite thioguanine triphosphate gets incorporated into replicating the DNA and halt replication and blocking the pathway for purine synthesis. The most common indications we'll see for azathioprine nowadays are autoimmune conditions like Crohn, lupus, or inflammatory bowel disease, as well as sometimes used for post-transplant immunosuppressant agents. A couple of the most common adverse drug events to look out for are gastrointestinal, so nausea, vomiting, diarrhea, leukopenia, thrombocytopenia, and pancytopenia, risk of infections, hepatotoxicity, and pancreatitis. So going over kind of the metabolic pathway of azathioprine, starting off with mercaptopurine, which gets metabolized into thioinosine monophosphate. Both of those get further metabolized by TPMT to methylmercaptopurine metabolites, which are inactive. And then the thioinosine monophosphate also gets further metabolized into thioguanine monophosphate, which then gets phosphorylated into thioguanine diphosphate, and triphosphate, which is the active metabolite that integrates into the DNA, causing that mechanism of action that we are looking for in thiopurines. Thioguanine kind of enters the pathway a little downstream, and it gets metabolized directly into thioguanine monophosphate and follows the path there. It also has a pathway for TPMT to deactivate it into methylthioguanine there. And then azathioprine, like mentioned earlier, is a prodrug of mercaptopurine, so enter a little upstream from mercaptopurine. NUDT15, the role of that is to deactivate thioguanine triphosphate and bring it back as a monophosphate. So if any of these are deficient, then you can see the pathway gets pushed towards the active metabolite thioguanine triphosphate, causing more of it being integrated into DNA and seeing more of that severe myelosuppression that is at risk for any individuals who are deficient. When it comes to azathioprine metabolism, it's kind of interesting where there's some discussion about if majority of it happens first in the liver with first pass metabolism, and if that mainly occurs with TPMT, and then afterwards those metabolites gets travel into the intercellular where the mechanism of action occurs, like your bone marrow and blood cells. And the question is NUDT15 more significant in those areas, with that being in the last step of that metabolic pathway that we just saw before the thioguanine triphosphate integrates into the DNA. So that's a key thing to kind of think about when thinking about liver transplant recipients. When it comes to TPMT and NUDT15 testing, these are the AMP genotyping recommendations. So you have your tier 1 and tier 2. I just highlighted here the functions as well as the frequencies in these different ancestry groups. And the boxes in yellow are any frequencies above 0.1%. So just kind of making a note of that. CPIC azathioprine recommendation. So for the guideline, azathioprine was mentioned in a non-malignant condition with mercaptopurine. Individuals who are TPMT normal and NUDT15 normal metabolizers, the recommendation is to use standard dosing. If they are intermediate for either of the genes, then it's a 30 to 80% dose reduction. If they are intermediate for both of them, compound heterozygous, then the recommendation is 20 to 50% dose reduction. And lastly, if they're poor metabolizer for either or, then it's considering an alternative agent in these scenarios. In regard to the guidelines and transplant disclosure and recommendations there's no mention on how to apply TPMT and NUDT15 genotyping results to liver transplant recipients in the thiopurine guideline. However, the CPIC CYP3A5 tacrolimus guideline has a little paragraph in which they mention that in liver transplant recipients, the CYP3A5 genotype of the donor liver may not be the same as the recipient's intestine. In this case, it might be necessary to account for both the donor and recipients when determining the dose. However, the evidence around it is a little inconclusive, and how much of the recipient versus the liver contributes to that final serum concentration is a little unknown as well, and where in the time point of post-transplant if one is more superior than the other. The guideline did conclude that the recommendation is applicable if donor and recipient was found to be identical. When it comes to transplant testing, it's very tricky, and I don't think it's been explored too much within pharmacogenomics. From what I've seen, usually liver transplant recipients are excluded from any studies around pharmacogenetics, so the evidence is really scarce due to that. And there's a lot of ethical consideration when it comes to transplant recipients or patients in general, like availability of donor sample and like who has the ownership of those results from the donor, lack of evidence on how to apply both recipient and donor results, and how does this apply to all the pharmacogenes that we currently have guidelines for. Are there certain ones that we can use for these individuals because they do express in other areas besides the liver, or is it solely just we cannot utilize these results anymore because of the new organ that they have received? So in conclusion for this presentation, TPMT and NUDT15 variations do play an important role in toxicity profile for azathioprine. TPMT and NUDT15 genotype guided recommendations are available, but currently not for liver transplant recipients.